Hi, good afternoon. My name is Jazmin Cole, and I'll be speaking about PEG and Pediatric special considerations to avoid surgical gastrostomy tube placement. I'd want to start by thanking the moderators for inviting me to speak and the rest of the panel for all of the knowledge that they've shared so far today. I have nothing to disclose. During this talk, I'll discuss benefits, indications, and contraindications to PEG placement in pediatric patients and introduce anatomic considerations specific to pediatric patients. I'll then briefly review special equipment for pediatric PEG placement and long-term PEG care. And then finally, I'll introduce the more widely discussed question of PEG versus surgical gastrostomy. I'm trying to find the optimal technique for pediatric patients. Gastrostomy tube placement is one of the most common procedures performed in children. The most common indication is for nutritional support, for example, in children with failure to thrive, with short gut, with oral malformations like a cleft palate, or with metabolic diseases and specific nutritional needs. Other indications include the need for medication delivery or for gastric venting, like in patients with muscular dystrophies or those at high risk of aspiration. Gastrostomy tube placement and enteral nutrition benefit these children by improving their survival, not only because of better weight gain and quality of life, but also by facilitating an easier transition from out-of-hospital care to home care. Gastrostomy tube placement is also beneficial to caregivers and has improved their quality of life. And so it really is an important intervention for many children and their families. Absolute contraindications to PEG placement in children include an uncorrectable coagulopathy, including an INR of more than 1.5 to 2, or platelets less than 50, clear interposition of enlarged organs, or frank peritonitis. There are also several relative contraindications to PEG placement, which should be taken into consideration when deciding which technique for enteral feeding access may be best for a specific patient. And so patients with prior abdominal surgeries, spinal deformities, or catheters or shunts in place, as we've already discussed, should undergo radiographic imaging to better define their anatomy. Upper GI is the best test to do preoperatively, and that helps to rule out obstruction, malrotation, as well as situs inversus. Ultrasound is not a standard screening tool, but it can be helpful to evaluate organomegaly. And then finally, patients with active gastritis, varices, or peptic ulcer disease are at higher risk of bleeding and perforation, and so they require full treatment of these problems before PEG placement is considered. Dr. Drex already discussed the techniques for PEG placement, and these are fairly identical in pediatric patients, but children, especially infants, have a few important anatomic differences that change how we approach PEG placement and endoscopy in general compared to adults. And so the newborn esophagus is obviously smaller than in adults, approximately 5 millimeters in diameter and 8 to 10 centimeters long. The posterior wall of the trachea is also much softer than in adults, and so it's more easily compressed during upper endoscopy, even with an endotracheal tube in place. And since upper endoscopy in pediatrics is usually done under general anesthesia instead of the conscious sedation that we use in adults, this is an especially significant difference. And lastly, the antrum and the duodenum are at a more acute angle, and so they require a higher degree of tip deflection for adequate viewing. Again, some comorbid conditions like scoliosis, as shown in this 8-year-old patient on the right of the screen, as well as the presence of shunts or catheters, can limit optimal positioning of PEG tubes. The last consideration is that particularly in younger children under the age of 5, they have thinner tissues, which makes for easier translumination, but also places them at higher risk of injury to the transverse colon and to the gastrocolic omentum during PEG placement. And so overall, the smaller size of the esophagus and pylorus and the difference in tissue quality in children versus adults requires us to use special equipment for pediatric upper endoscopy and PEG placement. The American Society of Gastrointestinal Endoscopy published a status evaluation report of evidence-based guidelines for equipment to be used in pediatric endoscopy. Their recommendations are both weight and age-based, and so for children older than 12 months or weighing more than 15 kilos, a gastroscope with an outer diameter of 8 millimeters or larger can be used, and evidence also suggests that these patients can safely tolerate a therapeutic gastroscope with a larger outer diameter if necessary. For children under 15 kilos, an ultra-thin gastroscope with a smaller outer diameter of 5 to 6 millimeters should be used instead, again, because of the anatomic differences in esophageal and pyloric diameter and the risk of tracheal compression while the gastroscope is in place. PEG tubes of any size between 12 and 24 French can be placed, and tubes that are as small as 9 French should be used in infants. The ultra-thin gastroscope is a bit different than the standard adult gastroscope that we're all likely much more familiar with, in that it only has two-way deflection instead of four-way deflection, and therefore only has a single deflection control knob. It also has a smaller working channel of only 1.5 to 2 millimeters, but otherwise has the same working length as the standard adult gastroscope. Since PEG tubes can improve patient survival depending on the patient's indication and their other comorbidities, patients who had PEGs placed as children may present to adult general surgery offices or emergency rooms, and so I just wanted to briefly discuss long-term PEG care. As we've already discussed, feeds can begin 3 hours after placement, and then current guidelines recommend waiting 6 weeks to allow time for the tract to mature before exchanging that PEG for a lower profile device like a gastrostomy button. After that, the device is then exchanged every 6 months for balloon devices or once a year for button devices. And otherwise, patients are able to continue standard daily dressing care as we've already discussed. So an important question that's been raised in the pediatric surgery and the medical pediatrics literature is which technique for enteral feeding access is best for pediatric patients. And several studies have been performed to attempt to answer that question, investigating the frequency of PEG use versus surgical gastrostomy, complication rates, quality of life. The issue is that all of these have been retrospective studies and they've had conflicting results, and no randomized controlled trials have been performed comparing PEG and surgical gastrostomy. There are two large meta-analyses, one including 5,400 patients and the other about 1,500, both of which found significantly increased risk of major complications in PEG placement when compared to laparoscopic gastrostomy tube placement, and this was mostly due to visceral injury, but PEG had lower complication rates when compared to open gastrostomy. There's another retrospective study of 1,400 patients utilizing a national pediatric inpatient admission database that showed there was no significant difference in complication rates between infants undergoing PEG placement and infants undergoing surgical gastrostomy. And so the literature is certainly conflicting in this respect. And so in general, PEG is a desirable choice for enteral feeding access as patients have a single stoma site and experience shorter anesthesia times and operative times. It does require two separate, but again, short anesthesia events, and some patients may benefit from this over a single longer anesthesia event. The main concern surrounding PEG is that successful placement depends upon good transillumination and an endoscopic intragastric view without direct visualization of adjacent organs. And so that makes our ability to identify injuries in real time pretty limited. Surgical gastrostomy, on the other hand, requires more incisions, especially when performed laparoscopically, and longer anesthesia and operative times. The benefits are that surgical gastrostomy provides direct intra-abdominal visualization, and so in patients with prior abdominal surgeries and a concern for adhesions, or those with shunts or catheters in place, or with organomegaly, this may be a better option for them. The exchange after surgical gastrostomy can also often be done in an outpatient clinic setting and doesn't necessitate a second anesthesia event. And so what's the verdict? Which technique is best? The short answer is we don't know, and our current scholarship is yet to be able to provide consistent evidence in favor of one technique or another. The key seems to be careful patient selection, taking into consideration each patient's comorbidities and anatomic specifications, as we've already discussed. The patients who are more medically complex require thorough preoperative workup with upper GI imaging and ultrasound imaging, again, to rule out malrotation, situs inversus, and to evaluate for organomegaly that may preclude safe PEG placement. And then lastly, but very importantly, is individual physician comfort with one technique or another. And so in conclusion, PEG is a safe technique to be used in children needing enteral feeding access. Current guidelines recommend a standard pull-through technique, as has previously been described, followed by an exchange for a lower profile device once the tract is matured. Patients benefit from a thorough preoperative workup and close considerations of concurrent disease processes to allow optimal patient selection. But at the end of the day, you should use the technique that you're most comfortable and familiar with, and trust your gut. Thank you.